Hello, and thank you for joining us today. My name is Emily Arnold, and I will be co-presenting our case study with my UCSF colleague, Shannon Fuller. We will be sharing findings from our rapid response study examining access to HIV prevention and care services for immigrant community members impacted by shifting immigration policy in the US following the 2016 election. The election of Donald Trump in 2016 ushered in significant and dramatic changes in federal level immigration policy and programming, beginning in 2017 when he took office. These included significant budget cuts to refugee and resettlement programs, cuts to health and social services for immigrant communities, increased deportation and detention of immigrant community members, including a more visible presence of immigration and customs enforcement officers, particularly in urban immigrant communities, militarization of the US and Mexico border, and finally, changes to public charge, which are a set of rules that weigh use of public programs and services that are then applied when individuals seek to change their immigration status. We know from the literature that anti-immigrant policy can have spillover effects, significantly impacting the health of immigrant communities more generally. There are substantive tensions between the federal and state level policy landscape surrounding immigration, particularly in California. California has an estimated 2.4 million undocumented residents and has progressive policies to protect and care for them. These include the California Values Act, which was enacted in October of 2017 and prohibits the use of state or local resources to assist with federal deportation efforts, the Declaration of Sanctuary Cities, including San Francisco, Oakland, and Los Angeles, which was recently upheld by the Supreme Court and also posits that local police officers will not assist immigration enforcement officers with deportation. And finally, the recent expansion of Medicaid public insurance plans for all residents up to age 26, expanding comprehensive coverage to all low-income adults regardless of their immigration status. It was within this dynamic and shifting policy level landscape that we began to hear that clinics serving immigrant communities impacted by HIV were experiencing loss to follow-up within their patient cohorts. We therefore decided to field a rapid response study to determine the impact of changes to immigration policy and law following the 2016 election and what steps clinical, social, and public health staff were taking to continue to provide HIV prevention and care services to immigrant populations in Northern California. We conducted in-depth interviews with 20 key informants in 3 Northern California counties, San Francisco, Alameda, and Fresno, from May 2018 through January of 2019. Interviews lasted between 60 and 90 minutes and were audio recorded and transcribed. Themes were inductively and deductively established, and our analysts defined those themes into a coding scheme and applied the codes across the data set. We interviewed our key informants on a variety of topics, including current role and their patient population, clinic services and the funding streams that supported those services, best practices for maintaining access to care and prevention services, and patient experiences since January of 2017, as well as stories of any patients that have been lost to care since January of 2017.
Okay, thank you, Emily. I'm going to provide an overview of our findings. First, here's a description of our sample. Roughly 1/3 were providers, another third were case managers or social workers, and then the remaining third were legal or policy experts or clinic administrators. We've grouped our findings into 2 major areas. One, the changes that informants noticed after the 2016 federal election, and 2, best practices for maintaining access to HIV care or related services for immigrant communities. First, the perceived changes. One of the first and most common responses when we asked participants to describe the changes that they had seen among their patients was this sense of urgency for legal services. There was a general concern and confusion around what rights could be stripped away, and that fear was one of the driving forces that seemed to lead to the sense of urgency for legal services. In the quote here, a case manager talks about how they're seeing this happening even for people who have permanent residency in the US. When talking about the prevalence of anti-immigrant rhetoric and acts, they note, quote, "It really does seep into your psyche. And I think that there becomes this community level of anxiety and a heightened sense of urgency to address legal needs." In terms of the impact on clinic attendance, the patterns seem to vary depending on how well connected the patient was to the clinic. As one provider explained, quote, "It's a mix of two experiences. One is for my more established patients. They come in and tell me that they're scared, and we talk about that and about the resources and support. For my newer patients who have been undocumented, people who have come in the last year and a half or so, some of them have actually disappeared." Similar patterns were observed in other settings, and informants really underscored the importance of building and maintaining trust with patients. Another major theme was the fear about accessing public services. This was distinct from fears about leaving to go to the clinic, but rather had to do with concerns about how use of services such as housing assistance, food stamps, and public insurance would impact immigration status. Here, one of our informants explained that, quote, "For the most parts, many folks are not impacted by the proposed changes to the public charge. However, given the fear around the rule and the misunderstanding from our populations, we've seen a lot of folks pulling back and asking to be disenrolled from programs." In light of these challenges, there were a number of ways that clinics and other agencies had tried to support immigrants. Medical legal partnerships had existed for years in the context of HIV care and support. However, many of the clinics and agencies had developed additional partnerships to better support immigrant communities. For example, many clinics had referral networks to attorneys or legal aid organizations specializing in immigration. And a number of providers talked about writing letters of support that could be used for patients seeking asylum. One of our legal experts spoke about the value of partnerships between legal services and medical care providers. Quote, "There is a special synergy that you get when you know the providers." She goes on to say it made it so much easier with that kind of trusting relationship to be able to get the kinds of documents we needed to support our cases and vice versa. Informants also emphasized the importance of providing culturally sensitive care. As a case manager explained, quote, "The experience changes when the work is client-centered and non-judgmental. Having someone who has perhaps been through the immigration process before, someone who looks like them, someone who speaks their language, is really, really helpful in making people feel comfortable seeking care." And finally, the flexibility to provide services in different locations was critical in reaching patients who may have been scared to leave their homes or otherwise have difficulty accessing the clinic. In the quote featured here, one of our informants in Fresno talked about providing HIV testing services outside of the clinic for migrant farm workers. And we also heard stories in urban areas about clinic staff meeting patients at train stations or in other locations when there were fears that immigration officers were monitoring the area around the clinic. So that was a brief glimpse into our major findings. And with that, I'm going to turn it back to Emily to talk more about the implications of the study.
Thank you, Shannon. There are several implications at both the clinic as well as the policy level that we would like to share with you. Trust in clinic staff who were culturally sensitive and trained in immigrant rights proved to be a key ingredient in maintaining engagement and care. Instituting patient-centered care models and delivery of healthcare and wraparound services may be particularly important to consider moving forward. As we rely more on telehealth during the COVID pandemic, trust and open communication with broad teams of providers is going to be essential for maintaining connections to care. While the interpretation and enforcement of the changes to the public charge rules are still somewhat unknown, we did gather the impact of these changes on willingness to access health services, something that will need to be addressed through educational programs and outreach to the community more broadly. Finally, there is a need to establish and strengthen medical legal partnerships to take the impact of more restrictive policy regarding immigration into account as individuals also seek to maintain their health and well-being. We wish to thank our participants who shared their time and insights with us. And of course, we also want to extend our thanks to our funders at CHRP. Thank you.